Hello, Joel Dunning here at ESTS 2024 here in Barcelona, and I've grabbed Fernando, who is co-PI of the wonderful STABLEMATES trial, which is such an exciting trial that I think we're all going to really look forward to hearing. Just tell us a little bit about what is the STABLEMATES trial.
So the STABLEMATES trial is a randomized study comparing SBRT to surgery. And what we've done is we've selected high-risk but still operable patients. So these are the patients that you think are a little bit on the high risk. You don't really want to do a lobectomy on them, but you still feel you can get them through a wedge or a segment, and that would be what you would normally offer these patients. But we also feel that this is the best group to really look at to see whether SBRT would work. Because as you know, radiation oncologists are proposing that they use SBRT for all patients with small stage 1 lung cancers. So we feel that this is the best study group to look at to really compare the two therapies.
Yeah, and I think we just skirted through the fact this is a randomized trial. This is an amazing trial. How many centers have you got?
It's about 30 centers around the world, and most of them in North America. But we have a couple of centers in Australia, a couple of centers in Canada, and also in the UK as well. And frankly, our best enrollment has been from the non-North American sites. So we're really grateful to the help that we're getting from our colleagues across the ocean.
Yeah, and how many patients do you need, and how close are you?
So we're very close. It's about 270 patients, or about 240 at the moment. So we want to hit that number, and it's been a trial that's taken a long time because, frankly, when you do a randomized trial and you have two therapies which are very disparate, and you say to a patient, well, if you agree to this, you're either going to get surgery where we're going to cut you, or you're going to get radiation where you're not going to have an operation and you're going to be able to go home the same day. Patients will say, well, then why should I be randomized if these two treatments are the same? And so been the challenge, and a few other people have tried to do this, and in almost every case it's failed, and they've not been able to randomize patients between these two therapies.
Yeah, absolutely, with disastrous consequences in the literature where they try and mash together two terrible trials.
Exactly.
Exactly. And then a big shout out to the absolute genius Randomization Protocol. So obviously we're in your fabulous trial, and when you have a discussion with these patients in the MDT, that's when you randomize. And so they then come to you, and you only randomize to say, would you like to stick with me? And how did that come about, and how transformational was that for your study?
So we learned about this. If you go back to what happened with breast cancer, so for years and years, mastectomy used to be the standard of care. And so there was a trial many years ago where they randomized patients between lumpectomy with radiation versus mastectomy, and they struggled with enrollment. And then so what they then did was created this pre-randomization concept where you screen eligible patients, and if they are eligible, you then talk to them about the study and the relative pros and cons, and go through that with the patient. And you say, you're eligible for this treatment, and this is what the normal standard of care would be, but this is the alternative standard that's being used, and you go into the why this might be better or why the other thing might be better, and you say to the patients, if you agree to this, we'll randomize you between the two. But you really try and present that to the patient with equipoise, and it requires the surgeon who's doing the trial, and requires the radiation oncologist who's doing the trial to have equipoise and to be able to communicate that to the patient.
And just finally, sort of how many years you can do follow-up, and when do you think it'll first publish?
So, we wanted a minimum of 3 years follow-up. So the study has taken so long that we're going to have more than that by the time we complete the study. And I think if we have 4 years, 5 years worth of follow-up on most patients, I think we'll be in good shape. And it'll be the first randomized trial to complete. There is one other trial that's ongoing, which is a study that's being done by the VA, and it's called the Valor trial. And they've been able to enroll, but they're also struggling with enrollment, but they're doing well. But they're looking at a VA population as opposed to the general population that we all see.
Right. Well, congratulations, an amazing study, and amazing that you are definitely going to finish.
Yeah,
great job.
And I want to, any of you who in the study, we want you to get us over the finish line. I'll put that plug out there and help us get that, so we can really look at the data and come up with some meaningful commentary on how we should use SBRT and how we should use surgery.
Fabulous, great. Well, thank you so much, Fernando, and great job with the study.
Thank you very much.